Hello, everyone, and welcome to our third Mobile Health Lunch and Learn on the Go. It's good to see each of you. I am Cindy Manginelli, and I'm the Director of Community Engagement at the National Healthcare for the Homeless Council. I'm really pleased to be hosting you today for this third installment of our Mobile Health Lunch and Learn. I am hosting the session, but our session is funded today by the Leon Lowenstein Foundation, and we have been honored to partner with them to do a significant amount of mobile health work. If you are new to the series we've been doing, in September, we did a couple of two sessions on safety and security in mobile units, and in October we did 2 sessions on billing for services in mobile units. You can find those on our website. I'll put my email address in the chat, so you can also email me if you're interested in those. And then we have had the last 3 weeks, this is the third week in a row, which we're doing our Lunch and Learn series. So our Lunch and Learn series is a little bit different. We're hoping to do something really informal. We actually limited the number of people who could attend because we wanted it to be very interactive. The first week we featured a mobile health unit in Alameda County that was mostly operating out of vans and talked about sort of their philosophy there and the work they were doing in an enormous county with hundreds of people, thousands of people experiencing homelessness. Last week we talked to St. Mary's Legacy, which operates out of rural East Tennessee. And they showed us pictures of their unit with chickens walking all around, and totally different than Alameda County. And then today we're gonna go into a different part of the country from that. But if you are interested in recordings of those, please reach out to me and I'm happy to get those to you. If you're not familiar with the National Healthcare for the Homeless Council, we are a national training and technical assistance program. We do advocacy work, policy work, trainings, technical assistance, webinars, publications, toolkits, all kinds of things at the intersection of healthcare and homelessness. And I will put my email address in the chat, and you'll see our website is at the end of my email address, NHCHC.org. And we have tons of material on healthcare and homelessness, and also a significant amount of material on mobile health. So I would encourage you to check that out. We also have friends who are partnering with us on the work we're doing with the Lowenstein Foundation from the Mobile Healthcare Association, MHA. And if you are new to mobile health, or if you've not heard of the Mobile Healthcare Association, I would encourage you to check them out. They have a ton of information and resources on their website as well. Feel free to put your name and where you're from in the chat, and it would be good just to give people an idea of where people are as far as their interest in mobile health. So feel free to put anything about yourself that you want in the chat. As I said, we really want this session to be interactive. So you can put questions in the chat, you can raise your little electronic hand, you can let me know if you have a question. I have questions that we have received through technical assistance through that we get through our website. So I have questions that I'll be asking too, but please feel free to put your questions in the chat. And we wanted this to be a small group so that you could take the time to ask what's of interest to you. We're going to be in this view probably for the duration of the next hour or so. So if you want, it might be easier for you if you go up to the top right corner of the black portion of your screen and click view and click speaker view. That may help you to be able to focus in on our speaker more through our session. Just an idea, whatever you want to do, you will be able to see it either way. I am super excited that Brandon Cook is joining us today. Brandon partners with us in so many ways on the council, and it's a name that we hear all the time at the council. I told several staff members that he was joining us today, and both of them said, Brandon, because everybody loves Brandon at the council and the work that he's doing and that his health center is doing. So I was so excited that he was able to join us today and tell us about the amazing work that want to make sure I say New Horizon Health Services is doing. So I am pleased to turn it over to Brandon.
Oh, stop, Cindy, just stop it. Thanks for having me. I really appreciate this opportunity to talk to everyone a little bit about what we do with our mobile medical unit. As Cindy said, I've had the honor to work with the council for a very long time, former board member, done a couple of other things. Currently, I sit on the steering committee for the Respite Care Providers Network, so very happy about that. Just some quick background on me very quickly, because as Cindy said, we want this to be very interactive. I want to do my spiel this much, so you guys have this much time to ask all the questions that you want. So just very quickly, Cindy said, I'm Brandon Cook. I'm based out of Greenville, South Carolina, with New Horizon Family Health Services. I am the director of the Healthcare for the Homeless and Medical Respite Program. I've been with New Horizon now for 17 and a half years. I started at the front desk, so check-in, patient registration, things of that nature. I spent some time in health information management as well as clinical support. And in 2010, I had an opportunity to really get involved closely with Healthcare for the Homeless and became the then program manager and now director. And so the Healthcare for the Homeless program for New Horizon has been around since 2005. That's when we received our funding. I'll talk a little bit more about that in just a second. And also, we extended our services by adding medical respite care services in 2019. We are a shelter-based model. So through our mobile unit program, we've made some excellent partners throughout the community. And so when we had this idea for respite, we had some allies who we could tap on the shoulder and quickly got them on board. And that allowed us the use of the total of 10 beds. We started with 6. We just added 4 this year, 6 beds for men in one shelter, 4 beds for women in another shelter. So we're getting there. We're still babies in respite, but we're getting there. So yeah, just a little bit of background on me, and for the sake of time, I'm going to keep it moving. So one of the first questions of note is, how's the program funded? So our community health center receives 330E dollars, and we also received a 330H funding. And so for folks who don't know, I'm making reference to grants that were awarded through Health Resources and Services Administration, that's HRSA. It's part of the Bureau of Primary Health Care through HHS. And so New Horizon has been funded for a long time through the health center program. And in 2005, we got the 330H funding. Our CEO at the time did a lot of legwork, got some community partners on board. They did a needs assessment and figured out that the community really could benefit from having a program that specifically was set up to care for people experiencing homelessness and ensuring that they could access primary care. The problem with what we lovingly refer to as the upstate of South Carolina is once you get outside of Greenville city and county, it gets pretty rural pretty quick. And so our population is spread out among many counties. Our entire service area, and y'all hold on for a second because I'm going to say this and it's going to sound wild, but I'm going to give you some context. So the upstate consists of 13 counties. What that means for us is, no, we are not actively in 13 counties. However, through strategic partnerships and other relationships in those communities, if there are individuals who are deemed eligible for our services because they're experiencing homelessness, and we can somehow connect with them, then we can cover them with our program. So we're based in Greenville. So we have 3 primary care offices in Greenville and a dental practice. So we understand that people experiencing homelessness don't always have transportation, and we wanted to remove as many barriers as possible. So when the program was funded back in 2005, one of the first things that our CEO said is, we're going to be able to do this, one, through strategic partnerships with area shelters and other agencies, but also with a mobile medical unit. And that's where we come in. So because there were so many community partners at the table at that initial award, if you will, we did get a couple of in-kind donations, and one of those was a mobile unit, gently used from one of the local hospital systems. My team quickly drove it into the ground. There are parts of it on our local highway. They basically hit a pothole and basically ripped guts out, not to get too graphic after lunch, but basically all the electronics and all that stuff was ripped from the undercarriage, and the team was on the side of the road, and we got them to where they needed to go. But suffice to say, we had to get another unit, and we were able to do that. I don't know if any of you all know, mobile units tend to be a little expensive. However, we did find one that was, again, maybe a little more gently used in Rhode Island, I believe. And so we had a person go up to Rhode Island and drive it back, and it did really well. And we had that mobile unit probably from 2007-ish until 2019. And during that time, we put a lot of miles. We went to a lot of places. We saw a lot of patients, and it's a very simple setup. 2 exam rooms, fresh water, vital signs, everything that we do in the office, we were able to do on the mobile unit. So in 2019, the simple story is we just came into some money, and we had an opportunity to build one from scratch, and we were super excited from that about that, because with getting hand-me-downs and old ones, they tend to be in the shop a lot. And when you're building relationships with partners and they're kind of relying on you and expecting to see you, and you say, oh, we're in the shop, it could put a strain on some of those relationships. So having a brand new unit that's built to our specifications, that's built for our area, our terrain, was really awesome. And we even went so far as to put pictures on the inside of kind of some of the iconic places of the upstate. So when the patients go in, we really try to make it seem like a regular doctor's office. Yes, it's on wheels, but we got nice pictures. We got a little skylight. It looks really nice. It doesn't look like, we're sending you around back to get second class or secondhand healthcare. So yeah, that was a long-winded way to say that we're funded through HRSA, y'all. So the kind of units that we use, so the first in-kind unit was basically a giant RV style. The second 2 units, basically, essentially, a Freightliner chassis with what we call a box on the chassis. So just think of it as a really large U-Haul truck, for to help put that into perspective. Brandon,
one person asked, do you remember what the manufacturers were for those? They're checking into manufacturers and wondering what you recommended, if you remember that.
Sure.
You can also, after that, talk about what medical respite is and what you mean when you say medical.
Yeah, sure. Sorry. Yeah, so I don't know about the in-kind from the hospital, that very first one. No clue about that one. The second 2 were built through Lifeline Mobile. And they're, yeah, we love them. They're super responsive with support, especially in the very beginning when we're kind of getting used to, especially the new mobile unit. Very helpful with that. So yeah, Lifeline is who we used. And then circling back very quickly, medical respite is the Cliff Notes version, is essentially providing a safe place for individuals who are experiencing homelessness, who are being discharged from the hospital with an acute illness or injury. Too acute to be discharged to the street or to a normal emergency shelter, but not acute enough to remain in a hospital. And so having those respite beds really allow people to go to a safe place and recover, but also engage with staff and get access to providers, medications, things like that are going to help them not only recover, but also help them get access to benefits. And in some cases, we've been able to house a few people as well. I'm happy to say, in the time that we've been in operation, we've never had to discharge anyone back to the street that stayed with us through the completion of their treatment. But everyone doesn't stay with us through the completion of their treatment for a number of reasons. But yeah, the folks that stay with us, we really do our best not to send them back to the street if we can help it. And so far, so good on that. So yeah, but excellent questions. We are looking at expanding the program, and because we are so rural, and the resources kind of dwindle away as you move outside of Greenville County, we're actually looking at getting a smaller sprinter unit that would go with another team. And I'll talk about who's on the team in a second, but go out with a smaller team that can go to some of those smaller shelters that maybe have a much smaller capacity, that you wouldn't necessarily want to use a ton of resources, or it might be costly to send a lot of resources. To put that in perspective, to fuel up the big truck and send it to a shelter that only has a max capacity of 10 people is not going to be the best use of that unit. So we really try to get to the shelters that have much higher capacity. That way we're kind of getting the biggest bang for our buck. And the patients, tend, in those bigger settings, tend to have a lot more issues going on. And so we want to be able to put those resources in front of those folks. So those are the types of vehicles that we've used. I know there's a ton more. The thing with mobile health is, sky's the limit. Whatever your imagination can kind of think of, that's what you can really do. I think someone kind of has a small truck that has like stuff in the bed of it, and they just get in and they rip and run, and they do it that way. So there's a lot of ways you can do it. But if you're going to use a big unit, we try to go to the places where people really congregate and gather, and so we can really capture a lot of folks at one time. So the other thing with the size of our mobile unit, so our mobile unit is 35 feet long. It is about 13 and some change high, and I want to say it's about 15 feet wide without the side wall expanding out. So it has a generator. It is a diesel engine. But the important thing, especially for us, was the weight. We did as much as we could working with the manufacturer to get the weight as minimal as possible. So I'm just going to say what it is. So we wouldn't have to require folks to have a CDL. Because when you start having to require CDL, there's a lot more hoops and regulations you have to go through. Not saying that we want to do anything on the sly, but to get that level of credential in folks, it can be hard to find. Truck drivers usually have those type of licenses, and they're definitely going to make more money driving their trucks for whoever compared to driving a truck for an FQHC or an HCH program. So by keeping that weight down and just having the ability to have just a regular operator's license really gives us a lot of flexibility, right? I can drive it. Most of my staff can drive it. If they can't, it's very easy to train them on how to drive it, especially if they've done a lot of moving in their life and they've been behind the wheel of a medium-sized U-Haul. It feels practically the same. So there is a little bit of training. Just again, it's a big vehicle. You got to get people used to how it turns, and one of the things that we try not to do is not back up. Backing up can be tricky. So if we don't have to, we really try not to. But aside from that, anyone can really drive the thing. And just to put that in perspective, in our old unit, the last one that we had, one of my staff who was a medical assistant, we trained her to drive. And it's, like I said, that unit was 40 feet and pretty similar dimensions. And the poor thing, she was 4'10", and she still drove the truck. My guy that rode with her because he's still with me, he's 6'2", and she would have to slide in his bench seats. So she would have to slide the bench all the way up, and I actually had to buy her a little booster seat so she could see over the steering wheel. But she never had a wreck. She never had any issues. She never ran into anything. She never ran anyone off the road. We never had any issues with highway patrol or anything like that. But my point is, as long as you have a decent training program and you really hold people accountable for the size of the vehicle, you shouldn't have a whole lot of issues. So yeah, anyone can drive it. One of the things that helps to bring the weight down is we don't have a bathroom. The reason why we don't have the bathroom is because there's a lot more maintenance when you have a bathroom, and especially waste disposal. It's a little bit different from the gray water that you get from just washing your hands and kind of pouring things down the sink versus an actual septic system that you have to, because you can only clean that system out in certain places, very specific places. If you're just cleaning gray water, you have a little bit more flexibility on where you can go to drain and refill that. And it cuts down on the weight. And most of the shelters, not most, all of the shelters that we partner with, if we need someone to give us a sample or specimen for a urine, the facility is very close at hand. We just have them go in and use the facility restroom and bring the specimen back to us. It's never been an issue for us. On occasion, we have had folks provide a specimen in the room because we didn't quite do a good job of explaining, but that's very, very rare. But the staff don't chuckle about it until many, many months later when they're looking back at it. But yeah, so those are types of vehicles. That's the weight, the size. One more thing to say about the vehicle. So we have 2 exam rooms. We have storage space. We have, because I know this will come up, the way we connect when we're out in the field, we do have, and y'all, I can't get too technical because I'm not in IT, but we basically have a wireless router set up on the mobile unit, and we can connect, and our EHR is web-based. So it's a little easier just if we have internet connection to connect to our EHR, and it's on a secure, right? It's secure through our internet, and it's also secured through the EHR system. So we don't have to worry about any kind of security issues with that. And again, just about anything that we can do in our brick and mortar offices, we can do out there. We can do urine samples. We have a microscope out there. We have a centrifuge. We have all the stuff that you need to draw labs. We have 2 refrigerators. So we can carry frozen specimens, vaccines, things of that nature. So we really try to bring as much out on the mobile unit to give to the patients as possible. And I'm trying to think, and we also have a wheelchair lift. The biggest difference between the old unit and this newer unit, especially with the wheelchair lift, is we got some space back when we built this new unit. Our old unit, the wheelchair cradle was inside of the mobile unit itself. And so what that did is in that second room, and the nurses would kind of fight over who's working up patients in that room because they lost so much space because you got this big clunky wheelchair cradle in that back room. With the new unit, they were able to construct it in such a way that it stays outside and underneath the mobile unit. So when we deploy it, it actually comes from underneath the mobile unit, goes up to where it needs to be. There's a door that opens from the outside, and the person can, if they're on a walker or in a wheelchair, it'll raise them up, and it's secure. It's a little cage, so no one's going to roll off or go anywhere. And it takes them up to the room, and they can go in, and we can let the lift back down, and that's how we get folks on the mobile unit that can't otherwise use the stairs. So yeah, that's it. I'll keep it moving. So we'll talk about some more stuff.
Here's a quick question in the chat. Yep. So do you require a CDL license for any of your staff now, or do any of your vehicles require that, or have you totally gotten away from that?
So the only unit, and I think we're getting ready, so we also have a mobile dental unit. I'm gonna be honest with y'all, I don't like it. Can't stand it. The reason why I don't like it is because it's basically a trailer, right? And it's a tow behind trailer. And so because it's such a large trailer and it takes such a large vehicle to tow that vehicle does require a CDL. There's only a handful of people in the entire organization, and we're budgeted for 300 and a little over 300 employees, and we're currently at about 220. And I think there's only 3 people that can drive that in the whole organization. So it's not in my wheelhouse, it's not my unit, so I don't care. No, I'm kidding. But that's the only one. The other ones, all the other vehicles, there's a couple of minivans that I have as well. None of the stuff that I operate under my program requires a CDL. And again, we really did that so we could train people very briefly, very quickly, but very safely on how to operate the unit. And that way, if someone calls out sick, we're not having to cancel, a whole day of sites. We just say, oh, hey, okay, you got to drive because, Brandon's not going to be here today. And I can drive it. A bunch of my staff can drive it. So it really lends to the flexibility. More questions on that? All right. So the types of patients that we see, so we were very intentional about this. We really only go to shelters, emergency shelters, and a couple of day shelters. In the past, we've been to soup kitchens. And I know there are some units that are small enough and flexible enough to go, under bridges and park at certain businesses and things like that. We set ours up intentionally to partner with shelters because for us in our community, we know that's where the most folks are going to be, right? They're either going to be at a day shelter, getting other services. So it's a great opportunity for us to be there while they're already there. They're going to be at a shelter, getting services at the shelter, at the emergency shelter. And if we can be there while they're there, it's better for us as opposed to kind of go into some known hangout spots where there may or may not be folks there. Again, for us, if we're going to deploy resources, we want to try to capture as many folks as possible, and partnering with the shelters really allow us to do that. And then when we get them on the mobile unit, really what we're doing is we're doing primary care. The trick with that is, and you guys know, our folks that are kind of living rough and living on the street, especially for extended periods of time, their chronic issues first present to us anyways as very acute. Diabetes is a great example. Someone's diagnosed 3 years ago and has not had any medication, and his sugar is super out of whack. And, it's kind of a bit of crisis at that moment. Blood pressure is another good one. Folks hadn't had access to those medications. Blood pressure is just super out of control. So we try to get them out of crisis as much as possible and then get them well managed. The other trick with that is it's kind of some of our folks are here today, gone tomorrow kind of. So it's really a balance. I try to have the providers not get too frustrated by that because sometimes they order everything. They want to give the patients the world. And I appreciate that. We really love that. But we also have to, come back to reality and just understand that some of our folks are just going to have different priorities. And health isn't always one of those, right? They just want to get out of crisis and then go about doing what they need to do that's going to work for them. So we really just do what we can to build those relationships and try to meet the patients where they're at, both physically where they're at and also where they're at with their healthcare, and just try to provide the best services that we can from that perspective. So we also provide access to prescription medications. And when I say provide access to, all of our primary care locations have a pharmacy. And what'll happen is after a visit at a shelter, either my staff will pick up medications and drop them back off to the shelter, or we have some pharmacy staff that will go out to the shelters from time to time and drop off the medications there. That way, again, we're not, requiring people to have to figure out transportation to come to our pharmacy and pick that up. We can take it to them. In some extreme cases, we've had shelter staff come and pick up some meds and then go that way. So really, it doesn't do them any good if we can kind of diagnose and address some issues, but we can't treat them. So, having the prescriptions available is pretty important. And then also, we do referrals. We send people to specialists. We pay for transportation if transportation is an issue. Yeah, and obviously vaccines and lab work and all that stuff. So again, have to emphasize we really did as much as we could to make it feel like a regular doctor's office, right? So anything that you're going to get at the doctor's office, we're going to do our best to get it to you at the mobile unit, and then some.
A question about your partnership with the shelters. So when I've worked in shelters, we would have a mobile unit come, or more frequently we would, take someone to the health center or get them to the health center. And there were things that I really wanted to advocate for the patient for. For example, hey, he may not mention this, but his leg looks like it's got a hole in it. Just something like,
Yep.
I think he's going to you for a sore throat, but I also think, he's in liver failure or whatever. But there was no way for the shelter staff to say to the healthcare provider, we're really concerned about this, if the patient didn't, state that themselves, and vice versa. They would send people back into shelter and be like, he's got to take this medicine, or he's got to see this specialist, but they weren't allowed to tell us that. And if the patient, for whatever reason, wasn't able or chose not to communicate that, we weren't able to support each other. Do you have any sort of way that you work with shelter staff to mitigate that? And then secondly, when you go to these programs, if individuals walk up but they're not actually receiving services at that shelter or that day center, are they allowed to be seen too, or they really have to come through the location where you've parked?
Got it. So excellent questions. So the first one with how we engage with the shelters. So a lot of shelters do, when they have folks come in and become residents in their programs and in their shelters, they kind of have them sign off that the case managers have some ability. Can't tell them, the bank codes or anything like that, but have some ability to communicate with staff, because they understand that some folks just aren't good historians or don't really do the best job that they could at presenting the issue, or sometimes just don't do a good job of communicating, period. And so the shelters that sign off on that have a little bit more flexibility. Not every shelter does that. So my staff tries to be as in tune as possible. So the check-in staff will ask questions. The nursing staff, before they get to the provider, will ask questions and really try to dig it out and really try to figure out what's going on with the patient. And we've been doing this so long now. Some of the patients, we know them. We interact with them on a fairly regular basis. So they might tell us one thing, and we have the ability to go to doc and say, okay, this is what Brandon said, but we also noticed that, he hasn't been taking his meds like he's supposed to, et cetera, et cetera. So we do have the ability with some of our patients to give the doc kind of a heads up. And help me out with the second part of your question again.
Yeah, and then actually someone added to this in the chat. So are people able to just walk up, whether they're receiving services at the location or not? And then it was added in the chat, do they have to make an appointment? And if so, does that appointment go through the shelter, the day center, or do they make that appointment with you? What does that process look like with your partners there?
Got it. Yeah. So it depends. To the first part of that question, it really depends on the shelter. So probably our largest shelter provider, they're what we call a closed campus, right? So basically the only folks that can receive services from us would be folks that are actually on their campus. And they do that just because they want a secure campus, and that's just how it is. But we do go to day shelters, and it's come one, come all. And the soup kitchens tend to be that way when we've gone to soup kitchens in the past. There's also a newer youth shelter, youth drop-in center that we just recently started going to. So we're excited to see how those numbers grow. But again, it's going to be little bit more targeted because it's youth as defined by HUD, so it's 17 to 24. So we're going to see how that shakes out. If they know, so we actually asked the youth drop-in center about this. If they kind of know someone that's kind of outside of that definition, they could potentially come on site and be seen. But that's definitely going to be a case by case. In terms of appointments, so I guess technically yes. The shelters basically we've given the shelters a list, and we say this is how many we think we can see in a given time. Fill it up. So essentially, the residents of the shelter get with their case managers or the counselors, and they say, "Hey, I got such and such going on," and they'll add them to the list. Sometimes, depending on how frequent we go to a site, the provider will say, "Hey, we'll be back in 2 weeks. I want you on the list." And then my staff will kind of communicate with their counselor and say, "Hey, listen, make sure Brandon gets signed up the next time we come, because we really want to see him back." So I guess that's technically an appointment, and it kind of goes through the shelters. As far as our EHR system, we really don't put, we get the list sometimes in advance, sometimes the day of. We really don't put anyone on our schedule for, our EHR workflow until we get there, because, if we have 15 names on the list, you kind of don't know what you're getting until you get there. It might not be the same 15 people when you actually show up. So we try to keep it flexible on our end, because people, again, have different priorities. Someone, just had a job opportunity and they thought they were going to be able to be seen, but this job is more important than, getting a refill on, blood pressure medicine. We would say the blood pressure medicine is more important because it'll probably keep you employed a little bit longer, but we get it. We just try to be accessible. Hopefully that answers that question.
Yes, that's very helpful. We had another 2 more questions.
Yep.
Are you billing any insurance, Medicaid, Medicare, commercial insurance, et cetera? If you are, did you have to put the homeless shelters addresses in your scope of service?
So we are in a non-expansion state, so we don't have a ton of opportunity to file insurance. But it comes up every now and again. Our mobile, so the shelters are not added to the scope. Just the mobile unit is. So the mobile unit is the operating site. It just goes from place to place. If folks want more detail on that, I will have to do a little bit of talking with with my leadership to get the verbiage right. But essentially, instead of because that would be monstrous. Every time we added a new site to our schedule, to go back through HRSA and have to add that shelter as a site, we were like, no. There's got to be a better way. And for us, it was making sure that the mobile unit was the site of operation, and it could move around, because that's what mobile units do. But if folks wanted more detail, I can pull up and get a little bit more specific on that.
Yeah, that's what we do. The sites that I've worked with here in Tennessee, that's what we did too. And the shelter site was really irrelevant. It was the unit with the site. Are you 2 more questions? Are you able to do blood work and get results at the same time as the visit? And I'll add to that, if not, do you communicate? How do you communicate what results are if it's something that can't wait until the next time you're there?
I don't know of anything. There is some point of care. I know you asked specifically about blood work. There is some point of care testing that we do that we can get results back right then and there. Most of our labs are going to, like CMPs, things like that, CBCs. Those are going to go out to. We work with LabCorp, and the results come back that way. So the way we try to reach patients, especially with abnormal results, is there's a few ways. One, we're going to try to contact them directly. Some of our folks do have their own cell phones, even though they're in a shelter. So we'll try that. We'll call the shelter directly and leave messages. Hey, this is Brandon calling from New Horizon. Can you please have Mr. Joe Bob call me back? That works in some very specific occasions. We can reach out directly to the counselor and communicate that way. It's really difficult to do that. There has to be a lot of things in place for HIPAA reasons, but it has happened from time to time. And then in some cases, you know, I hate to say it this way. How can I say this better? We do our dead level best to find people or to make direct contact with people. And that's really how we try to do it.
Yeah, that's awesome. That's the unit we talked to last week did the same thing. They said sometimes we've driven up and down the street, you know, if it was really a serious result. Yeah, that's awesome.
Absolutely.
How do you screen for the sliding fee discount, and who does that? If you don't know who you're seeing until the day you get there, how do you screen and get documentation as far as sliding scale fee?
Yeah. There's not a whole lot of pre-gaming for us because we don't always get the schedule or the list, as we call it, ahead of time. But we do have some staff two staff, my outreach person who also can drive the mobile unit. And then I have what we call a patient service representative who also is our certified driver, if you will. And so they're responsible for registration, checking in patients, things of that nature. And a lot of it they do on site. Now, when we get the list, what they try to do is navigate through the list. If there are folks that are actually there and are on the list, we try to prioritize the established folks first because there's so much more work, paperwork involved with new patients. If we can go ahead and kind of get the train rolling with folks that are already established, paperwork's already done, there's nothing to update, we go ahead and get them going so the providers can start cooking. Then we can work on the paperwork that goes with new patients, including for us, most of our folks are going to qualify for the ACH grant. And so what that means is we got a little form, they fill it out. My staff will vet it, which is really easy because what we're looking for is what their living situation is, how long they've been in that situation, what their insurance benefit looks like, what their income status looks like, and if there's any other, especially medical benefit that they have that we could utilize. My staff is there. They're at the living situation. They know, you know, either through the patient or from a counselor, so they can answer all of those questions and then put them, we have a pay source in our EHR, basically it's healthcare for the homeless, and we put them in there for a set amount of time, and essentially we're footing the bill for their.
Hi.
Hey.
No, I was just pacing in my meeting.
Sorry, go ahead.
I was gonna say, I don't know if that was for me, but hey, you muted yourself too, Cindy.
Yes, I muted them, but if you're talking to us, feel free to unmute, but it sounded to me like maybe that was an off conversation. So go ahead.
Yeah. I lost it.
So you have staff at you know where they live. I mean, you know they're homeless because they're staying in a shelter. So I guess that gives you an advantage too. And so normally if you had people bring in a letter from a shelter saying I'm homeless, I have no income, you've got that because they're there. Yeah.
Right. So that's one. Thank you. So most folks are going to qualify for the program. The folks, to get to the question that was actually asked, the folks for sliding fee, our staff, we have all that paperwork there. We have some flexibility, right? So if someone only has a paycheck stub, so depending on how they're paid, we may require 3 check stubs, we may require 2, just depends. But if they have 1, we can start with that, right? We don't have to, if they have nothing, we have a process internally, we call it self-declaration, where they basically declare what their income is. We'll put that in the system will kick out a pay code. And then we'll give them some time to go back and get us the appropriate documentation or help them with the documentation. And that's how they're able to apply for sliding fee. And then of course, our folks that have insurance, We get a copy of the card, we put it in the system, the meds, the referrals all go through that. So, but that's an excellent question.
Yeah, thank you. We get asked that a lot, and both
Yeah.
in mobile units and in
Yep.
healthcare for the homeless in general. So that's very helpful. I think probably going to the shelters helps with a lot of these things too. Do you have any radiology equipment on board, and do you take payments? Not for the radiology equipment. Two very unrelated questions, but
So no, we don't. We don't have any radiology. We do have relationships with some imaging places, as well as, well, not so much a relationship with the hospital, but what I try to do is with the independent imaging facility, I have contracts with them. So we get people sent over there. And again, with the transportation, we cover the transportation. So if the provider orders imaging, we're going to get that scheduled. And if folks need a ride, we're going to cover the ride to make sure that they get there as well. So that's how we kind of overcome that. Payments, I'm gonna be honest with you, even if we have someone that is on our sliding fee scale, we don't take any money in the field. So they kind of sort of get a pass. We can bill them later or whatever the case may be. We used to do money in the field years and years and years ago. It's just too much. It's just too much of a hassle for us. So we kind of give them a free pass. We bill them. We send them a bill later for the slide. But again, the majority of the folks that we see out in the field are going to be qualified on our program anyway. So, so let me back up for 1 second. So the answer to your "do we take payments" question on the mobile unit, no, we don't deal in any money. In the primary care locations, absolutely. If someone needs to get on a payment plan, not a problem at all. Most of the folks that are in shelter are going to qualify for our lowest slide. And that's $15. That's our nominal fee. And basically it's their copay, and then we write everything else off. So the sliding fee folks don't get any kind of secondary bill or anything like that. They just pay the $15. If you're being up, you pay your copay, and then there could be a bill on the back end for lab work and other things like that. So again, the whole thing for us is just making healthcare as accessible as possible. So that's why we're set up that way.
Thank you. We currently don't take payments, so we defer the payment, but we're looking into because we're gonna start providing like clinic, flu clinic stock. So for that they have to pay. So maybe looking into the electronic, but not cash payments. I was just wondering.
No, it's an excellent question. Yeah, good question. It's just for us, I just hate dealing with cash in the field. and yeah, I don't know if I want to put any more strain with on our humble little system with electronic payments either. So we just prefer to, next time you're in the primary care, or send them a bill for that later. But yeah, excellent question. So really quick, because I know we're coming up on time, and I just want to let you guys know who's on the mobile unit. So the staffing on the mobile unit obviously you're very welcome. Is obviously a provider. Currently we have two, one that gives us 1 day, one that gives us 3 days, and then we have a day for admin. So because we're out in the field Monday through Thursday, there's not a whole lot of time for follow-up, because basically when they come in, they get a few minutes for prep time, and then they're on the road. So Friday really gives them an opportunity to kind of not only tie up loose ends, but make those calls, follow up with people. Even the newest provider that we have now, she even gets in there and she makes some of her own phone calls, which I'm sure our CMO would prefer she not do, but if she's feeling it, we're not going to stop her. So there was a question that popped up about if we have non-traditional hours before I talk about the rest of the staff. No, we still do bankers hours. So the staff comes in at 8 in the morning. They're usually out the door by 8:30. I feel like we do a little bait and switch on them. We tell them when we hire them 8 to 5, but truth be told, they stay out in the field until everyone that's there to be seen gets seen. So case in point, we were in another county yesterday. They didn't finish and get back to the house until like 6:30. So it's just one of those things. If we can mitigate overtime, we will. Usually that means an early day on Fridays, an early start to the weekend for the staff. But that's how we try to do that. We're not at the point of doing non-traditional hours at this point. But a great question. So in addition to providers, currently we have a vacancy in our LPN position, but that is a position that typically goes out. We also have an RN level nurse educator that can really work in conjunction with the provider. So a really good, for instance, is if the provider has a newly diagnosed diabetic, instead of spending all of her time and energy kind of trying to do some diabetic education, she can just work on the basics, get the patient seen and taken care of, and then put in an order for this nurse educator to follow up and do a much more in-depth diabetic teaching and instruct people foods, how to do your insulin, all that stuff, which we like because it frees up the provider to kind of focus on the more acute needs, and then sending the nurse back out into the field to really kind of help folks understand how they can manage their particular disease where they're at. It's one thing to kind of get those instructions in the office where, and talk about ideal scenarios, but it's very different for the nurse to be able to understand and see where you're at, what kind of access do you have to food, what types of food do you have access to, and how you can work with your diabetes based on what's there, what you have access to. So we find the nurse educator super, super helpful. But when there's no LPN, we can also lean on the RN just to get back on the floor and help with working patients up and rooming patients as well. We also have a medical assistant that goes out with the mobile unit. I've already talked about my patient service representative, who's also a driver, and my outreach guy, who's also a driver, and helps with the patient check-in. And that's pretty much it. Sometimes I'm out in the field, but I'll be honest with you guys, the staff tells me get out the way. So I try to stay out of their hair and just let them do their thing, and because they're good at it. And I think our partners love them more than they love me, but that's all right. See, Cindy, not everybody loves me. No, I'm kidding. But yeah, so what's left? So challenges. There's so many challenges, and I don't know if we have enough time, so I'm gonna try to hit the highlights. The biggest challenges can be the mobile unit itself. Again, when we've had the older units, the used units, the hand-me-down units, they stay in the shop. It really puts a strain on those partnerships that you have with shelters and other agencies and locations, and even with the patients themselves, because ideally, sometimes if the mobile unit doesn't go out, they're just not getting healthcare, or they're going to the emergency room for things that they really don't need the emergency room for. That argument has helped my mobile unit go out in more than one sticky situation between myself and the CMO. Y'all won't tell her I said that, but yeah, it's very important to me. I don't like to cancel sites for that very reason. So what that challenge has forced us to do is think about how can we continue to do what we do when the mobile unit is in the shop or having some kind of routine maintenance that takes a little bit longer than expected. And so we've come up with this kind of secondary thing where a lot of the stuff that we take, a lot of stuff that we use on the mobile unit, we can actually pack up a good majority of it in a minivan. And most of the shelters that we partner with have some location or two locations on site where you can have the check-in staff be in one location and the staff for the provider and the nurse to be in a separate private location. And we've made it work that way because, again, for me, it's super important not to cancel any sites. People are expecting to see us. People want to see us. We've lost providers in the past, and we've had to pull providers from other sites, which my colleagues internally. I get a lot of side eyes when I have to do that. But that's what we have to do so we can continue to see people in the community. And we've even leveraged telehealth. Some patients take to it better than others, but it still allows us and affords us the ability to be able to address some of these healthcare needs in the field if we can't physically be there with the mobile unit. So that's one significant challenge. And then the other challenges is things that, we're all kind of facing. There's staffing issues, as I mentioned. I've got the one vacancy with the LPN. And also in expanding, we have to add additional staff, and that's just not coming as quickly as we would like it to. So staffing is always a bit of a concern. And I'll tell you guys this, I also think it takes a very special provider to work the mobile unit. I don't know how else to say it. They just kind of got to get it. They got to kind of understand the population that we're working with, and just have a slightly different approach than you have when you're in the physical office. So yeah, that can sometimes be a challenge because you can have a really great provider in the office, and then it doesn't translate so well out in the field. And that's the nicest way that I can say that. And then the other challenge for us is our organization is sandwiched in between two really big hospital systems, both of whom have said, we can do mobile unit too. So that's another challenge that we face. Fortunately, we've been doing it longer. We've been doing it the longest, and we've established a lot of really good relationships. And so it's really important to us to keep those relationships very strong because people trust us, people rely on us. And so we do our best not to let those folks down. And yeah, so that's it. Yeah, I could talk hours about challenges, but I know we're right up against time, and maybe we can squeeze in another question before we have to turn it over.
Thank you so much, Brandon. That is so helpful. I learned a lot. I really appreciate the insight on patient education, and having worked in a shelter for years, so many times patients would come back with these instructions or these prescriptions, like they can't do that here. And so I think it would just be invaluable to have a nurse who says, I see where you're living, I see what the rules are, I see what's practical, and we're going to make this work. Because boy, that was a huge, and still when I work with shelters, a huge challenge. It's like, where does this provider think they're going to go and get all this stuff? And, and then there's the poor, the patient thinking, well, it has to be this way or I'm going to die, and like, oh my goodness. But thank you so much. That is so incredibly helpful. I would encourage, feel free to, I put my email address in the chat. Feel free to send me questions. If you have more questions for Brandon, I'm happy to pass those along. I know many of you have been requesting the recording to share with your teams. I'm going to have the recording. Feel free to do that. We'll have that for you, just like we have the last few times, and we'll have others that registered that will watch the recording as well. We will not post it to our website just because of the questions and stuff. I just didn't want people to feel like they had to think through what was going to be posted, but we will have the recording for people who registered. And then next week is our last Lunch and Learn on the Go series, and we're going to be talking to a program out of Arizona, which I think is going to be really cool, very different demographic, even than the others that we've done. So feel free to email me if you have more questions for Brandon. Feel free to go to their website. Thank you so much, Brandon, and everyone have a great afternoon.
Thanks, everyone. Appreciate you all. Thank you.